We are live. Hello, Vikram Talaulikar. It has been actually quite some time since we have spoken. How are you?
I'm fine, Fiona. How are you?
I'm all right. I've had better
Thank
days.
you. Thank you for organizing this today. Always a
That's all
pleasure to
right,
speak to you.
because this is one of these really confusing things. But before we actually really start getting into the nitty-gritty of HRT and endometriosis, I wanted to throw a few things at you because there's been a lot of very confusing things that have been going on lately, and people keep saying, I'm just confused. I'm seeing one person saying this over here. I'm seeing another person saying this over here. I don't know what to actually believe anymore. So there seem to be a couple of themes that this all boils down to, and they are: first one is HRT safe?
Yes, HRT is safe as a medication. It is one of the medications which has benefits risk. If you want one word for it, yes, it is safe for majority of women as long as you stick to how it should be taken in the proper way.
All right, that's easy. The other one is, we have a group of people saying you should be taking HRT as a preventative measure for dementia, for heart disease, and then you've got another group saying, well, hang on a second, we're not there yet. Why can we not say that yes, you can take it for dementia and heart disease at this stage?
No, because we don't have the research. So any medication, may it be HRT or any other medication, every person's response, every person's need for the medication will be different. When you generate guidelines, when you formulate guidelines, you're really making them as a generalization for everyone. You're not making individualized decisions. So guidelines have to be very responsible when they're made. They have to be based on what is the right thing for everyone or most people. And so when we look at use of HRT, we know it certainly is fantastic for symptoms, for quality of life. There is no two ways or arguments about that. The argument comes is, can we recommend HRT to everyone to protect their bones as long as they live, to protect their heart as long as they live, to protect their cognitive function or prevent dementia as long as they live? We don't have a generalized evidence for this. Yes, there will be groups of women who might benefit from staying on HRT or continuing to take HRT or starting HRT for their bones, for their cognition, for their heart. But they could equally be harmed if, for example, HRT leads to the adverse event. For example, they get endometrial cancer, they get breast cancer, they get a stroke or a blood clotting event, then they would be harmed. And then you could say, oh, the guidelines said that everyone should take HRT to make their long-term health better. But what about those 5 in 1,000 women or 10 in 1,000 women who get an adverse event and die prematurely or have adverse quality of life because of the treatment they have to have for that condition? So you can't generalize. All we can go by is look at research more carefully, do long-term research beyond 60s, beyond 70s with sufficient number of women. Look at how many women will actually have the benefit, how many women will have an adverse outcome. Because of it, they may suffer in quality of life or have comorbidity or premature death. Those sort of comparisons on a larger scale over 20, 30 years, we haven't got now. So the guidelines cannot recommend that everyone should take HRT for their long-term health. That's different from seeing an individual. Let's say if I see an individual, they know their family history, they have a peculiar medical history, they have their lifestyle, they may be exercising more or less, they may be eating healthy or not, they may have other comorbidities. If I see them, when I know what their genes are, what their family history is, they may have a one-to-one discussion with me to say, actually, my decision is, I'm fine if I get that small adverse event later on in life, but I would like to have benefits for my long-term health for the next 20 years. And they may decide to choose to have HRT for that reason, and I will offer it. So that's different in the individual scenario. One can make that decision after the patient has a discussion with their healthcare professional, because the patient choice finally should be respected. But you cannot generalize that, because we need better research to make generalized guidelines to say, can everyone take HRT as a longevity medicine solution?
People would come back to you then and say, well, hang on a second, we've got studies now that show that there's no problems with all-cause mortality for people on HRT. We've now had this very recent one out of Canada, I believe, with a retrospective of 110 women who were over 60 and had taken it for a much longer period of time.
So they are against small numbers. So those
Yeah, so
studies are not enough for me right now to say I have enough sufficient data and evidence to recommend this as a guideline going for future for next 20, 30 years. We will need hundreds or at least tens of more studies, large observational numbers running in thousands over years, or good randomized control studies in women after 55, 60 with modern HRT to really say, is this worth recommending as a long-term health solution? We simply don't have that evidence now to recommend that as a generalization.
then the argument would be, well, hang on a second, we can't wait for 20 years to have this evidence. We're seeing that, women are getting on better with this now. Why do we have to wait?
So that's where the individualization comes. If you're a person who believes that you would benefit rather than everybody around you or everybody with a different medical history, different gene, different lifestyle, if you think you are one who will benefit with HRT long term, then that's a discussion you have with your healthcare provider who you trust. You can tell them about what your thoughts are. The healthcare provider can assess your medical history, comorbidities, exercise, diet, why you think the HRT may be more beneficial, then the chances of you getting some of those adverse events in the long term. And if you make a decision with your healthcare provider, yes, I would like to actually take the benefits rather than risk, that's the right decision for you. Nobody is stopping you continuing or starting HRT later on. But
All
that's
right.
one-to-one. That cannot be generalized yet. Maybe in future things will change, and we hope it will change, but we're not there right now, which is why it's really important to individualize benefit risk and make one person advice rather than a generalization at this point.
All right. The other thing, the third leg of the stool, testosterone, very strong push at the moment to be saying that, it's a female hormone and therefore obviously we should have it replaced. Is there any logic to that argument? Or is
So
it
again, I don't believe everyone needs testosterone. If I say 100 women in my clinic, actually many just don't have the symptoms due to lack of testosterone. They often choose to go on estrogen, progesterone, HRT and are absolutely happy after that. They don't have residual symptoms, problems with libido, problems with energy, bone muscle, nothing like that. They're pretty happy on HRT or non-HRT interventions otherwise. Some women who do have, say, lack of libido, sexual dysfunction, may have other brain fog, mood, energy, would like to consider testosterone for this. I don't say no. The main indication, of course, is low libido, but we often say there is no indication or no evidence that is there for brain fog or mood changes or energy levels. Do try. We do a trial of testosterone for 3 months or 6 months. If libido improves, any other benefits are there, fantastic, you carry on. As I said, we did an audit at our own hospital to see how many women were actually continuing testosterone beyond 1 year. And 80 to 90% of them were all continuing beyond 1 year, citing continued benefit, not just for libido, but for brain fog, for energy, for clearer thinking. Now, randomized control data is not there for this. We don't have the evidence that actually these indications should be listed for testosterone. A good trial might get these indications on board, but until such a time, it's individualization. We speak to the woman, tell her where the evidence lies. It's for libido. Is this something that's going to benefit anything else? Yes, no, we don't have evidence, but it might. Give it a try. As long as you stick to the licensed dose, as long as you're aware of what side effects to expect, and if it helps you, continue. If it doesn't help after 6 months to 1 year, despite maintaining a good blood level, it's not for you. And there are 10% of women who are coming off because they don't see any benefit with the testosterone.
There you go. Interesting, because actually I think in Australia they say it's around about 60% get a benefit. And so you're seeing quite different things, and it'd be interesting to find out why. There is a question, speaking here about levels and recommended levels, there's a question over here from Lana asking, can HRT cause dangerously high levels of estrogen?
It can if you go over and above what is recommended. So remember that the HRT is designed in a way that certain amount of it will be absorbed from the preparation that you take. And we often say that if you're on the highest licensed dose of a preparation, such as say 100 patches, 3 sprays, or 4 pumps of gel, you're going to hit levels hopefully around 300, 400, 500, 600 picomole. That sort of a range is where you're going to be. If you consistently hit levels more than 1,000, that worries me. And that's because physiologically the bodies have been designed, and again, there's not a lot of evidence for this, but you kind of go by what estrogen levels most women would be exposed to during their reproductive years. So let's say between 15 to 45. And you often average out, because estrogen varies in the cycle, it goes up and down. If you average out the levels, you find that usually estrogen levels will be around 300 to 350 picomoles a day. That's the sort of level you're trying to aim for. Does that correlate clinically? Yes. Majority of women, when they hit the levels above 250 picomole, do extremely well. Their hot flushes, night sweats, and sleep symptoms are gone. They feel better. We often see on bone density, once you're hitting levels of 250, 300 picomole, your bone density will stabilize or go up if you're at risk of having low bone density. So we know that's the clinically effective dose of estrogen for majority. You will always have the outliers who may not absorb estrogen, who may need more, but those are extremely small group of individuals. And you will often know that because their blood levels will not go above 200 or 150 picomole. But if you consistently use higher than this estrogen, if you're using, let's say, more than what is the upper recommended dose, if you're getting levels in thousands consistently, we simply don't have data to know what's the effect in 5, 10, 15, 20 years. That's why we are trying to be cautious. We're trying to say, yes, you can go very high on estrogen dose, very high levels in your blood. What we don't know, in the short term, you may be fine, but what about 5, 10, 15, 20 years? Is there a risk of cancer more than we quote with the licensed HRT? Is there a risk of any other problems with liver or any other organs higher than the one that we quote with the licensed dose of HRT? We don't have answers, which is why we are trying to be cautious.
Very true. Some would argue that you do have the answers. You've got the trans community that can tell you that they're quite happily going on very high doses of either testosterone or estrogen, depending on which direction they're going in. Surely that is sufficient evidence.
No, that's not sufficient evidence because the context changes. When you're a science person, you got to look at exact evidence in the same group of individuals with the same physiology. In that sort of particular population, the studies done cannot be directly extrapolated to women because, again, the context changes, the study population changes. In fact, it's interesting that there was data presented recently at one of the international conferences which suggested there was high incidence of blood clotting and stroke using high doses of hormones in this particular population. And there was a call to say we have to be cautious with using high dose even in trans population. So no, like has to be compared with like. You cannot choose two different scenarios to give the same information on a subject.
Okie dokie. And the last one I will ask on this before we get on to endometriosis and the things that we really came here to discuss tonight. Fezolinetant, there was a change to the safety warning on it because of a very, very rare event that apparently seemed to happen to one person with liver complications. So basically they were saying if you start to show signs of having liver issues, jaundice or whatever, then to stop taking the drug. Should people be worried about fezolinetant, or is worrying about that something that happens to a very, very rare consequence, because all medications have side effects? How do we put that into perspective?
Again, all medications have side effects, all medications have risks. There are very rare side effects of almost every medication, including your being sensitive to it. What is important is to go by what the product recommends, what the trial data shows. And again, this is important to pick up. For example, this particular incidence of having liver issues, and then making guidelines whether anybody else would need have monitoring of their liver enzymes in future. All this is part of post sort of marketing or post use of the drug. So any new medication, when it's used, will always show you some new side effects or some data in real life scenario that may not have been captured in a randomized trial situation. That is exactly why new medicines often get monitored as soon as they have been released. This particular one event should not deter people from considering the medication. It's a very useful non-hormonal option for women who wish to or not take HRT, or even women who want to avoid HRT because of side effects or any other issues they've had. I wouldn't change my practice with that. What I would certainly do is keep an eye out on how the research pans out. We're learning about this new medication, and as we keep learning more, just like with HRT, we prescribed loads of HRT in the 80s and 90s. Then people realized when the WHI data came out, yes, the data had lots of problems, but it gave us hints that there are certain preparations like oral tablets which can cause blood clotting and stroke. There are some preparations, oral synthetic progestogens, which can cause, for example, breast cancer risk to be higher. That's how we learned about HRT. Then we moved on to a safer preparation of HRT. This is all part of learning when you use a medication. And it's right that this has been pulled up and is being monitored and watched for. But again, that doesn't change the practice for now. For majority of individuals, when the benefits outweigh the risk, the drug is safe to use.
Okay. One more question, because just because this one is unusual. A lady taking oral estrogen and her levels have never got past 25. So how do you manage that? I mean, that you wouldn't. I wouldn't. How does that happen?
So you can have women who can just not absorb any estrogen from the oral route. Let's say if they're taking a tablet or a capsule. You can also have the same with a patch, gel, and spray. We have had women who've used very good levels of transdermal HRT or oral HRT, and in the blood, the levels are often less than 40 picomole. They're not common. It's unusual to not absorb any. Usually you will have some absorption, maybe 50 or 100 picomole. But if that does happen, there are plenty of other routes and doses you can try. There will be some way that your body will absorb estrogen better. You can try that route or dose. And again, here is the point, is there are many women who will be listening to this particular webinar and saying, oh, but I don't absorb, and you're talking about licensed doses. This is a different scenario. So when we talk about non-absorption, so for example, you're not absorbing through oral route or transdermal route, and you're not getting enough estrogen in your blood, that is a valid reason when you cross the licensed dose. Because we know you're not absorbing enough, your levels are less than 200 all the time. We do then recommend crossing the upper limit of the licensed dose, because there is a reason why we do it. What is worrying is crossing the licensed dose and having more and more estrogen, but you're crossing into thousands of picomoles in your blood. That is the scenario we want to avoid, because we don't have data for future.
Yeah, that makes perfect sense. All right, endometriosis. Let us get on to that topic, which is because this is such a complicated area. I mean, people spending decades getting diagnosed and then finding it really, really hard to manage. Just so I'm assuming that most people who are here are actually watching this probably know what endometriosis is, because that's the reason why they've come. But for those who might be watching and don't, what is it? And basically, what is it and how do you manage it?
So endometriosis is presence of endometrial tissue, womb lining tissue outside of the womb. It could be in the pelvic cavity, in the rest of the abdomen. It could be in the chest. It could be in some unusual sites, such as some parts of the skin. And every time you go through a menstrual cycle, the womb lining bleeds, there's menstruation. A similar change happens wherever the lining is present. So if the womb lining is in the pelvic cavity, next to the ovaries, behind the womb, next to the bowel, bladder, it will undergo those changes and have some bleeding, have some inflammation. And over a period of time, as the cycles continue, there will be lots of inflammation, immune reactions locally, there will be scarring, sticking together of the tissues, and all those inflammatory changes will follow. It's a horrible condition, because even if you treat it, it keeps coming back. Recurrence is a problem. Even with surgery, 50% of patients will have recurrence by 5 years. And so what we haven't done well is there continue to be delayed diagnosis, there continue to be dismissal of symptoms, there continues to be delays in referral to the right place. Not many places have the adequate expertise for surgery, imaging for endometriosis. And finally, when they get to a place which is for referral to a specialized center, again, they may be let down because of lack of resources, long waiting times, and not getting sufficient help when they go back to their GP or primary care. So lots of problems exist in the current care, and we have let down patients. We're not doing great with care for endometriosis, which should be across the life from puberty until menopause and postmenopause.
All right. So before we hit menopause, or when we're hitting perimenopause, how do we manage it then?
So I think throughout, say, the years when the woman is having menstrual cycles, the main sort of problem for majority of individuals will be period pain, dysmenorrhea, heavy menstrual periods, chronic pelvic pain, pain with defecation or gut use, bowel use, pain with bladder use, and of course painful intercourse, and then problems with fertility. Those will be the primary sort of symptoms during the reproductive course. During perimenopause, many of these will worsen significantly, because you kind of having that accumulated damage over your 20s, 30s, 40s. There's maximum inflammation happening by the time you're getting to your perimenopause. And often the periods being irregular will not help. There's more heaviness, there is more pelvic pain. Often endometriosis exists with a sister condition, adenomyosis, which brings in more pelvic pain, and all that doesn't help. The symptoms tend to be more pronounced. And at this point, it's either medical management or surgical management. And those two will be the main pillars of managing it before you go through menopause.
All right, so what do you mean by medical or surgical management?
So there are various ways of managing endometriosis. You have sort of painkillers, you have hormone manipulation, you have blockers such as GnRH blockade, and then of course you have surgery. And it's, I think, probably not enough to go through each one in details. We will run out of time, but the essence is, for the pain, it's usually simple painkillers, including something like paracetamol or Nurofen, right up to specialist pain management with heavy painkillers in specialist centers and pain management teams. With hormone manipulation, it could be a contraceptive pill, which is usually taken back to back to avoid bleeds. It could be a progesterone-only tablet, for example, Dynogest or other progestogen. It could be progestogen-only pill, like a Cerazette or Micronor. It could be Mirena coil for some individuals that might work well. It could be hormone suppression completely, and that's using GnRH injections, which kind of induce a medical menopause. And then, of course, you have surgery, which is laparoscopy, which could be a simple laparoscopy, starting with a diagnostic laparoscopy and endometriosis ablation. But for deep endometriosis, you may need significant involvement of bowel bladder surgeons or specialist centers where you have a complete clearance. Those are quite significant surgical procedures.
And in terms of doing that, some people will just have the womb removed, others will have ovaries and everything removed. There's a big sort of spectrum there.
Yes.
And one of the questions that keeps on coming up from people is, well, I've had surgical menopause. Do I still need to be taking progesterone?
Yes. So the simple answer is, if you have had endometriosis in your life, and whether you go through a natural menopause after 45 or premature early natural menopause, and you're contemplating taking HRT either until 50 or even beyond if you're natural menopause, then you must take estrogen progesterone continuously, because this is a horrible disease which keeps coming back. And as we are becoming more, as we're more commonly prescribing HRT, certainly in my clinics, I'm noting women noticing endometriosis symptoms coming back. So if you want to avoid that, it's best to go non-cyclical HRT with estrogen progesterone. But if you've had a surgical menopause where you've had a hysterectomy and the uterus has been removed along with the ovaries, the traditional view was any hysterectomy, estrogen only, unless there was any endometrium left in the cervix with a subtotal hysterectomy. The tradition was estrogen only. You don't need progestogen because you don't have a womb lining. That's being challenged now because you could have enough endometriosis precursors in your pelvis. The peritoneum and the lining of the abdomen will have still some endometriotic precursors. And if you use estrogen only HRT, they have a potential to grow back. They can grow back, cause endometriosis, and theoretically, because it's not proven, could even influence the chance of them turning malignant, because it's womb lining at the end of the day. And if you're feeding it estrogen, potentially there's a theoretical risk that they will actually grow into malignancy. So any endometriosis that has caused you to have treatment that's significant enough in your past history, consider continuous combined estrogen progesterone, whether you've had a hysterectomy or not.
And does it matter what type of progesterone? Is one type of progesterone any better than any other?
Certainly, if you go by the experience with the bleed patterns and bleeding that happens on HRT, the traditional progestogens, like for example, the norethisterone, you have the Provera, the medroxyprogesterone, you have the one Dynogest, which is again a strong progestogen. Those tend to be better for bleed control, and they will have better suppression of endometriosis. But we know the problems with the synthetic strong progestogen. They're not good for blood clotting. They're not good for breast. And so, again, for most women with HRT, it will usually be the Mirena coil, and the second one being the utrogestan or the dydrogesterone, which is the body identical or body similar progestogen. These are weaker progestogens, not very good for stopping bleeding, but given that they have very little risk for breast and almost no risk of blood clotting, these will be the ones that we will primarily recommend on a continuous basis in a sufficient dose. And that's likely to be 100 milligrams of micronized progesterone if you're anywhere below a 75 patch or 3 pumps of gel or 2 spray. But if you're hitting the highest licensed dose, it's likely to be 200 milligrams of progesterone every day.
The other thing, I mean, I'm going to harp on for a second about the hysterectomy, and I mean, you did mention there if there's any endometrial tissue left around the cervix and things like that. Often women will go to the GP and say, you know, I've had a hysterectomy, but can I have progesterone? And they go, no, you don't need it. How do we get across to people that perhaps people who've had a even full hysterectomy may actually still need some progesterone?
I think it's getting better. So the GPs should be aware of this anyway. I know they are not always, but I think the GPs are getting themselves educated. There are so many programs happening now. We have so many coming to our MREF courses. I'll take a chance to mention that. But otherwise, it's important that the GP should already be aware, especially the meetings we do. We always say hysterectomy is not straight equal to only estrogen HRT. Hysterectomy has caveats. If somebody has had a subtotal hysterectomy, history of endometriosis, history of endometrial tumors, or endometrial carcinoma, or estrogen-sensitive gynae cancer, we always consider progesterone continuously. So this is being told to almost all healthcare professionals now through different meetings, education forums. As hopefully time progresses, women will not be denied the progesterone they need. Of course, it's not universal right now, but I think if a woman is not sure that the GP has done the right thing, maybe go back, have a conversation, say that I've had this in the past and the recent papers I read suggest that I should be on progesterone. If they're not sure, they'll be able to hopefully offer you a referral to the menopause clinic. I know it's a long wait, but at least you will get there eventually rather than the GP making the decision.
Are there any guidelines or anything that they could take in? It says here in the guidelines, it says this.
Yes, the BMS guidelines do mention the role of progesterone to be considered if somebody has significant endometriosis. Most guidelines now mention progesterone on its own or part of estrogen following an endometrial cancer, for example. There is guidance on BMS for the subtotal hysterectomy and management of HRT. So if they try to Google a little, they will get something to take with them. Otherwise, they can, of course, hopefully get some resources from us at MREF, which we are developing soon.
Yeah, you mentioned cancer there, or different types of tumors and things like that. So let's say I'm 48, gone through menopause, I've had a hysterectomy, and I've had cancer, but I have endometriosis. What are my options?
And it's the same. So if you had a cancer, and again, depending on the type of cancer, most women with gynecological cancer can now have HRT safely. There are very few tumors like uterine sarcomas or some sort of low-grade or high-risk endometrial or ovarian tumors where we often hold back on HRT. But for majority of ovarian, uterine, cervical tumors now, you're able to prescribe HRT. The thing to keep in mind is if they have had history of endometriosis, you would go continuous combined with both hormones, estrogen, progesterone, so that you prevent any reactivation of the endometrial disease.
Okie dokie. I'm just looking to make sure I haven't missed any early menopause. You mentioned the early menopause and having to be on both things, didn't you? I think I've covered all of my questions. Are there anything else? Any other things there that we should throw out there that I haven't thrown at you?
Well, I think it's important to look at endometriosis as a life course. And one thing that I would often say is, once you are on HRT, if you've had history of endometriosis, watch out for certain symptoms. So for example, you're the best person to know the kind of pain, discomfort you had with endometriosis before you had intervention or you had menopause that kind of kept it away. But remember, once you're on HRT or even without HRT, some women may have postmenopausal endometriosis. This has traditionally been neglected because all we've been saying is once you go through menopause, your hormones disappear and endometriosis is cured. It doesn't happen like that. A small proportion of women will continue to grow their fibroids or will continue to have some endometriotic disease continuing. And it can present for the first time post-menopause. In one of the recent media posts I did, I have put an article which is available on the PubMed, which actually discusses the challenges of diagnosing endometriosis in post-menopause. So if you're getting the pain that you had previously, once you start HRT or otherwise, the same kind of pelvic pain, the same kind of irregular bleeding occasionally, and this hints to or reminds you of the pain you had with endometriosis, then it's really important you go and speak to the person who prescribed you HRT or person who is looking after you for gynae health, because it could be the early sign of reactivation. Maybe you're on estrogen only HRT, you might want to add progesterone. Maybe your estrogen is too much, you're on 100 patch or 4 pumps of gel, and the progesterone is just 100 utrogestan, which is not very strong progesterone. So you might have to up your dosage to 200 milligrams of progesterone. Maybe you will need imaging. Maybe significant endometriosis has come back and you might need to have an ultrasound to look if there is any collection, any sort of pseudocyst, any sort of scarring, adhesions behind the wound next to the bowel or bladder. And you might even end up needing medical or surgical management even post-menopause. The reason I'm kind of concentrating on this is, as we are prescribing more HRT, we are starting to see the occasional individual present with reactivation and worsening of endometriosis. So if you are a person who's had it in the past, it's absolutely fine to take HRT, but make sure you're on the appropriate dose, you're looking out for signs of any recurrence, and if there are signs, you're having some sort of monitoring or imaging to make sure it's not increasing or reactivating. That's the key message here.
It's a gift that keeps on giving then, really, isn't it? Fun stuff. Brilliant. All right. I don't think I've got anything else for you. A couple of thank yous over here for having a very informative chat. When people want to find you, you are at the Menopause Clinic London. Where else can they find you if they wish to find you?
I hate this bit, Fiona. I don't want to promote here. So I think UCLH is the best place. I'm on the UCLH NHS clinic is the best one. Yes, there's a long wait, but eventually you will get there. I think that's the best place to kind of get best menopause advice.
Yes. How long is the wait?
It's probably for new appointments. It's beyond 1 year. And the follow-ups are even more difficult now. I'm just hoping that with the new sort of women's health strategies, we will get more resources in future. Don't want to sound too negative, but I think this is such an important area which has been traditionally neglected. Menopause HRT will be something that will be really increasing in future. And I hope whoever is listening to this call and has any influence for funding, please direct more funding for MREF and also for NHS for women's health.
Yeah, absolutely. 100% certainly needs it. Thank you so much. We shall speak again soon. And for anybody who wants to know, just to remind people, please subscribe to the MREF YouTube channel, because we've got lots of good interviews coming up. And there is a swathe of information already there. There's more on the Harley Street Emporium one because it's older, but eventually I'll sort of pull them all across. And, you know, it makes a really nice resource that you can go through and easily find that information that you need, like a streamable Netflix of menopause. So subscribe and tell others as well. And thank you so much, and we shall speak soon.
Thank you. Thank you everyone for giving up your time watching this. Thank you.
Take care.
Bye-bye.